Morning, everyone, and a very warm welcome on this particularly chilly morning. Certainly it is in Scotland. My name is Kyle Clark-Hay. I'm the Head of Governance and Resources at Public Health Scotland, and I'm absolutely delighted to be moderating what promises to be an excellent session this morning on the topic of the right to health. From a Public Health Scotland perspective, clearly this is very much part of our lifeblood as an organisation. And in Public Health Scotland, we want to see a Scotland where everybody thrives, specifically to see life expectancy in Scotland to start improving again. We want to see the difference in life expectancy between the poorest and wealthiest areas getting smaller. People in Scotland die younger than any other country in Western Europe, and people in our poorest neighbourhoods in particular die more than a decade before their neighbours in wealthier neighbourhoods. Poverty, poor quality housing, low paid work, unhealthy environments and access to services, unstable jobs all impact on people's physical and mental health. And life expectancy in Scotland hasn't improved since 2012, and healthy life expectancy is declining. So just some context, I guess, in terms of what the right to health for us means in Public Health Scotland. And I'm delighted to be joined by a wonderful panel this morning. So I'm just going to quickly introduce everybody on the panel this morning, ask them to say a couple of words just in terms of what the right to health means to them. So if I can start with Cath Denholm. So Cath is the Chief Operating Officer for Equality and Human Rights Commission. She joined the Commission in 2020 following 20 years of health service in Scotland in primary care, health improvement strategy, and latterly in the creation of Scotland's new public health agency, Public Health Scotland. Cath's interests are public service leadership, strategic change, and achieving value for money, firmly underpinned by fairness, equality, and human rights. She currently represents the Equality and Human Rights Commission on a variety of commissions across the world, and in particular the Scottish National Action Plan for Human Rights, or SNAP, as part of that collaboration since its inception in 2012. She's also a board member of the Joint Nature Conservation Committee in the UK and an honorary member of the UK Faculty of Public Health, and has been awarded for her work on human rights and public health. So very warm welcome, Cath. I wonder if you'd just like to say a few words in terms of what the right to health means to you.
Thank you, Kyle, and good morning, everyone. The right to health, for me, it's very simple. It is the ability, as you said, Kyle, for everyone to live to the best possible standard of health, mental health and physical health that they can. And as you said, I spent a long time working in public health in Scotland, in Health Scotland, which was one of the predecessors of Public Health Scotland. And our mission for a long time was to reduce inequalities in health in Scotland. And I think for me, that's when I began to develop a real interest and make a connection between our work in public health and the right to health, because if, as you'd already said, if people are actually dying younger because they are not getting access to the basic conditions that they need, whether that's an adequate standard of living or the right kind of housing or the right kind of education, that's fundamentally wrong. People are not getting access to the things that they need to live to the full potential. And it's about the right to health, and actually also fundamentally about the right to life. If people cannot live for as long as they should, or cannot live as healthily and as well for as long as they should, that's fundamentally why this is just so critically important, and why I spent all that time, and why it was great to see when Public Health Scotland came to life, continuing the work that me and many others had been taking forward through the Scottish National Action Plan and other things. So great to be here. Thank you.
Brilliant. Thanks for that, Cath, and a very warm welcome. Moving on, Anna Black. So Dr. Anna Black is a GP in Glasgow, working in a variety of different clinical contexts. She locums as a GP in Postle Park, which is an area of socio-economic deprivation, and Pollock Shields, an area of ethnic diversity. Anna also works as a GP in Glasgow's Youth Health Service, which is a service for 12 to 19-year-olds, and as a GP in Dungavel Immigration Removal Centre. In addition to this, she provides on-call GP cover to St Vincent's Hospital. Anna is one of our non-executive directors, a founding board member in Public Health Scotland. She's also a non-executive director of The Promise and a trustee, former chair of the Government Community Project. And until recently, Anna has also served as a Scottish Human Rights Commissioner. So Anna, do you want to give us a little bit of context in terms of why the right to health is important to you?
Hi, thanks, Kyle. Yeah, and thanks for the introduction. So I suppose in all my different roles, particularly in a GP role, I'm passionate about reducing inequalities in healthcare, and that's always been something that is been a real sort of driver for me in my work. And I think the right to health is, we're probably going to say quite similar things, I think, is that, you know, everyone gets the healthcare that works for them. Our health shouldn't be determined by social factors, often that are out with our control, or the results of sort of policy decisions. And I think just seeing, you know, in practice and on the ground, the sort of injustice in health that happens and the unfairness of sometimes how resources are allocated, you know, the inverse care law coming into play, and the bigger stressors causing ill health. And I think as we move into this cost of living crisis, that just becomes even more acute. So that's what it means for me.
Brilliant. Thank you for that, Anna, and a very warm welcome. Moving on to Donald McCaskill. So Dr. Donald McCaskill is the Chief Executive of Scottish Care. Scottish Care is the membership organisation of independent providers of care home and care at home and housing support services in Scotland. Prior to his current role, Donald ran an equality and human rights consultancy for 14 years, and in that time focused on issues such as workplace and institutional discrimination and the role of human rights in social care, as well as teaching and publishing in human rights and technology. He has a particular interest in human rights-based approaches to social care, support, bereavement and palliative care. So a very warm welcome, Donald. Do you want to just say a few words in terms of the right to health from your perspective?
Thank you, Kyle, and hello, everybody. So, as has already been indicated, my starting point is, I hope, a holistic understanding of what we mean by the right to health. And for me, that very much encompasses what Anna and Cath have already said about enabling individuals to thrive and flourish and achieve their full potential. But from a social care perspective, I see the right to health as being about choice, individual control, about personal independence, and the capacity to see yourself not just as a set of neurons and atoms, but as somebody connected to and with others. So for me, the right to health includes and incorporates the right to adequate social care, the right to palliative and end-of-life care and treatment, and most recently, and something I've been passionate about for a long time, is the right to bereavement support, because the whole of our life, whether it's physical or psychological health, is impacted by the reality that most of us at some point or other will experience the death and loss of a loved one. And that remains, for me, one of the great taboos which we're not very good at dealing with in Scotland. Thanks, Kyle.
That's brilliant. Thank you for that, Donald. And as I say, a very warm welcome. Final panel member, but by no means least, a big warm welcome to Duncan Isles. So Duncan is Head of Human Rights Policy for the Scottish Government, a post that he's held since 2011. He has previously worked on both environmental and constitutional policy. Prior to joining the civil service, Duncan worked for the National Museums of Scotland and in the academic sector. Duncan was closely involved in Scotland's National Action Plan for Human Rights when it was launched in 2013, and has subsequently supported work and proposals to incorporate international obligations into domestic law. Current priorities for his team include responding to the UK government proposals to replace the Human Rights Act with a Bill of Rights, and coordinating Scottish Government reporting against the requirements of UN and Council of Europe human rights treaties. So a very warm welcome. Duncan, do you just want to say a few words in terms of the right to health from your perspective?
Yes, thank you very much, Kyle. I thought it'd be actually quite useful to offer both a professional and a personal perspective. So from the point of view of a policy professional working in Scottish Government, very much thinking about the theoretical structure of human rights obligations and their application to the policy environment, it'd be quite helpful to comment quote from the general comment produced by the committee set up under the UN's International Covenant on Economic, Social and Cultural Rights. And this very much underlines the point that Donald's just made about the holistic nature of human rights and the interconnected way in which we should understand human rights obligations. So the general comment produced by the committee says, health is a fundamental human right, indispensable for the exercise of other human rights. Every human being is entitled to the enjoyment of the highest attainable standard of health, conducive to living a life in dignity. And this dignity theme, I think, is particularly important, and hopefully one we'll be able to come back to in the course of the seminar. The right to health is closely related to and dependent upon the realisation of other human rights. And of course, there's a big long list of those human rights. It's that critical idea that human rights are all interconnected, and that enjoying the right to health is necessary in order to enjoy other human rights, that I think is one of the fundamental theoretical points I'd want to emphasize and put across. But from a personal perspective, I have to say it matters to me because my mother receives social care support. It's absolutely excellent. I have to say the standard, the quality of support that's provided. Now, whether or not the people who have put in place that package, who are delivering it, have any understanding of the kind of theoretical human rights environment or what the International Covenant actually says about the right to health, I don't know. But in terms of how they act and the service they provide, they have absolutely nailed it. They are very clearly working absolutely in accordance with those expectations, with that structure, and with this fantastic emphasis on living a life of dignity. It's you know, absolutely exemplary in my experience, and it you know, rather nicely demonstrates how the theoretical and the practical actually join up. And of course, what we must be focused on is how, in fact, these rights, the right to health and of all of the other rights, are being realised in practice for people throughout Scottish society.
Thanks very much, Duncan, and thanks to all the panel members. Hopefully what everybody who has joined us this morning is seeing is a huge passion amongst our panel members in terms of the right to health. And I think, you know, that certainly makes for an excellent discussion this morning. I suppose before we really get into the details this morning, I suppose it's a question for all participants in terms of what does the right to health mean in your role? And I suppose that was one of the key questions that was flagged up just as you were waiting to join the session this morning. Before we start, just want to ensure that the technical bit, so this is not my strength, so colleagues, if they can keep me right if I get it wrong, but just the panel discussion today will include the opportunity to put questions to panel members. So if you haven't already done so, can you open the Q&A panel by clicking on the Q&A icon at the top of the screen in the toolbar? Hopefully that makes sense to people. And then when the Q&A opens, if you just type your question and click post, questions will be collected and presented to the panel. Clearly we have a huge number of people joining us this morning, which is great. It probably means we won't get through all of your questions this morning, unfortunately, but the fact that people are thinking about it, I think, is absolutely fantastic, but really looking forward to the discussion. So if we can move into that, Moira, just before I get into the discussion, have I missed anything?
No, that's perfect, Kyle. Thank you.
Brilliant. Thanks for that assurance, Moira. Okay, can we open up the discussion then? So I really want to start by understanding what we mean by the right to health. So what is the right to health, if I can open that up to the panel? Cath, do you want to?
Happy to go first, Kyle, if that's okay. Yeah, so what is the right to health? And there's many answers, and I think we've already heard some really good impassioned answers about what it really means in terms of the humanness and the experience that people have and the way that people care for each other. But I work for the Equality Human Rights Commission, and just to share, I suppose, some of the kind of concepts and legal definition a little bit more. So perhaps building on some of what Duncan's already said, but I think it's important. So the right to health, as we've heard, is the right of everyone to enjoy the highest attainable standard of physical and mental health for them. And it's enshrined in international human rights law. And that's really important to understand. It was first articulated, I think, way back in 1946 in the Constitution of the World Health Organization, and subsequently recognised within the International Covenant on Economic, Cultural and Social Rights. There are two components to the right to health, and it's really important, I think, to understand that. It's the right to healthcare and also the right to things that underlie the determinants of health, as we say. So all the social and environmental and economic conditions that people have referred to. So it's why, as people have said, it's so closely linked to the right to independent living, the right to an adequate standard of living, all those things. But to unpick it, it covers a number of different things. So it covers freedoms, and that's important. So it covers, for example, the right to be free from non-consensual treatment. And you can see why that's really important, for example, in the context of mental health. It's the right to be free from cruel, inhuman or degrading treatment. And you can see how fundamentally important that is to institutional care, to care of older people, to care of people with learning disabilities, etc. But it's also about entitlements. So it's about the right to a system of health protection and prevention of disease. And if we didn't understand that right 3 years ago, I hope we understand that right now in the context of COVID and everything that's happened. It's also the right of access to various things. So an example of that would be the right of access to maternal, child and reproductive health. That's really important. And certainly in England, we do know that women from ethnic minorities are more likely, for example, to experience stillbirth and maternal death. So why is that? So why is our right of access to those services, those critical services, not working in the same way? It's also about non-discrimination. It's about goods and facilities and health services being provided to people without discrimination. There's lots of examples for that. One of them would be the right for people with learning disabilities to get full access to screening and routine healthcare, which doesn't always happen. It's about availability and accessibility. That can be about waiting times, which is, again, really critically important as we've come out of COVID. That's a really important aspect of all of our lives. It's about inconsistency in access to services. An example of that might be IVF for same-sex couples. Another part about accessibility for services, which is really important, is about access to good information. And that links to something that Donald said earlier about you need information. You need information about your healthcare. You need information in order to make choices, and that you can have determination and agency and control over the choices that you make, but you cannot do that if you don't have information. And then last but not least, and we've talked about this already, but it is about those underlying determinants of health as well. It's about the right to food. It's about the right to housing. It's about having an environment, places to go that sustain your health and don't damage your health. And just to finish a little bit on the kind of legislative framework, because I think that's important to understand in terms of how we make this real in practice. In terms of in the UK has ratified the International Covenant on Economic, Cultural and Social Rights, but they have not been incorporated into domestic legislation yet anywhere in the UK. And that means that they're not currently directly enforceable in UK courts. It does mean that courts have to pay attention to them under the European Convention on Human Rights. And the Human Rights Act does mean that public authorities have a duty to respect and promote the rights. But it's not incorporated fully that it is, and that's why it's so exciting, particularly in Scotland, that the right to health in Scotland. And I think it's important to say and acknowledge that it is more progressive in Scotland than it is in other parts of the UK. I think Wales is starting to catch up. England, and I speak from across GB in my role, has quite a long way to go. So we mentioned the Scottish National Action Plan for Human Rights, and that's been progressive in realising things for many years. We've talked, I think, mentioned the Task Force for Human Rights Leadership, and that's leading to such exciting stuff, and Duncan will talk more about this, about the incorporation of the right to health and other economic and social rights and treaties within Scottish law. I mean, how good would that be? But I just want to end by saying that's about the legal status and definition of health, of the right to health. It's just an important right. It's hard to argue against, and it affects everyone. We've heard all of that. But I think the important thing for me is it's a progressive right, and that means that it goes beyond achieving minimum essentials. Now, the minimum essentials are really, really important. They're fundamentally important, but it is a progressive right. And I think that that means, and the thing that I always found quite exciting when I was working in public health in Scotland and talking about this, and it's still exciting, is that because it's a progressive right, it's a way of engaging people, it's a way of inspiring people. So even though we don't have all of the laws and all the things in place that we do have, these are concepts that people get, these are concepts that people naturally aspire to, people naturally want to provide services that work, naturally want to provide services that are caring, that provide that dignity most of the time. And the human rights language gives a language to people to justify that, to ask for the right resources, to set the right frameworks. And that can happen so that we can continue to improve services. There's something about the right to health. There's some fundamental basic rights, but even without all of that legislative framework, I think it inspires people to do better if we talk about it in the right way.
That's brilliant, Cath. Thank you very much. I think you've touched on lots of absolutely vital and critical concepts there, and I think certainly very much that is a really good description in terms of what that is. I wonder if we can open up to other panel members just to share their thoughts in terms of what is the right to health. Duncan.
Yes, I wonder if it's worth just picking up on the distinction that Cath drew there between the immediate realisation of rights and the requirement for progressive realisation. It sounds like a bit of a kind of techie point, a bit theoretical, but I think it's probably quite readily understandable from a health perspective. In essence, we have human rights obligations which the UK has entered into under international treaties. We have a requirement to make these rights real for everybody in society. But of course, that can be quite a complex undertaking. So it's quite common to break this down into two fundamental challenges. One is to deal with immediate requirements, in essence, the kind of acute challenge. Somebody has a life-threatening health condition and something, we need to take action to deal with that. So human rights, all human rights, not just the right to health, but all human rights are kind of understood as having a sort of minimum core obligation. So that requirement to do something now to address a situation that fundamentally threatens the ability to realise that human right. So in essence, taking somebody off to hospital and dealing with them as they have a heart attack is that kind of scenario. But of course, there's a much more challenging requirement as well, which is to progressively realise the wider set of rights over time. And we recognise clearly that it's not possible to do everything at once. But what we have an obligation to do is to ratchet up the level of provision in a way that progressively improves the realisation of a right. And if you think about long-term public health provision in that sense, what we're trying to do is raise the base situation, the base condition, in a way that enables everybody to enjoy increasingly better standards of health, increasingly better standards of care, having access where access was not previously available, having the availability of treatments that were not previously available, and so forth. So as a human rights concept, I draw attention to this distinction between taking immediate action and then this longer term requirement to ratchet up over time the overall standard of provision. And that, of course, in turn links into the hugely important emphasis that there needs to be on prevention as a requirement of, in all human rights contexts, but obviously in the context of the right to health, preventing health deterioration or poor health is clearly far better than trying to cure it after it has occurred and taken hold. So it's a really rather important concept, and I would emphasize the importance of it.
Thanks for that, Duncan. And I think, just that helps to illustrate, I think, what Cass clearly set out in terms of, that whole idea of upstream and thinking about, that preventative agenda. And I guess, certainly part of the work that we do in Public Health Scotland is very much related to how we work then together in that environment. Can you open it up to any other panel members just to respond to that? Donald, sorry.
Thanks, Kyle. So I think Cath's presentation was excellent, and I want to come back on something that Duncan has quite rightly said, that there is that dimension between immediacy of action and response and progressive realisation. I suppose, having been involved in various campaigns over the years around achieving human rights for particular groups, particularly older people and people with disabilities, there are different speeds of progressive realisation. You can be a snail or you can be a hare. And I suspect that for many activists in the human rights community in Scotland, our snail-like movement towards the realisation of the right to health or many other human rights is part of the problem. So it is not sufficient to have some of the best legislative presentations and content, I think, in social care, for instance, of the self-directed support legislation, and to have at the same time a massive implementation gap in the achievement on the realisation of the rights entailed in that legislation. So for all of us involved, whether it be in the right to health or the right to social care, etc., the challenge is, how do we hold feet to the fire to achieve the realisation of those rights and to make human rights realisation a destination rather than a dream? And I think far too often we're too cosy with the argument of, which is right, of progressive realisation rather than the necessity of speed in immediate application and adoption. Thanks, Kyle.
Thanks for that, Donald. I've got Anna coming very quickly on the back of that comment, those comments.
Yeah, I think just to kind of amplify, I suppose, what everyone else has said, and I think just really, I think as Donald was sort of saying, it's almost a call to action. I'm glad we're having this talk today. I think because I know from my my point of view, sometimes as a GP and other people working in health, it can feel quite hopeless, particularly at the moment. I think we're in a really acute situation, and I think we're in a critical moment in Scotland and probably in the UK as a whole, particularly sort of post-pandemic, and that's not to say that none of these health inequalities or difficulties in realising the right to health weren't there pre-pandemic. Of course they were, but they have been more than magnified since the pandemic. And I suppose coming back to what Duncan was saying, I like that phrase about we need to keep raising the base. And I suppose my worry just now is, if I think about it from where I work within primary care, I would say primary care is on its knees just now, as is most of the NHS. And I think a lot of the things that facilitate the right to health are having to almost be abandoned to deal with the demand at the moment, shortages, resource implications. And I worry that instead of raising the base, we're actually going to slip. We're slipping back because we're trying to catch up from what's happened in the pandemic. We're trying to catch up in a situation that wasn't great. And we're also trying to move forward and prevent. And I don't think at the moment we're able to get that balance. So I think that's a very pessimistic way to start the talk this morning. But I think that's it shows the acuteness of where we are.
I think it's really important to highlight the reality, Anna, and I think you've done that very clearly. And I think it is that whole notion really of where do we start, and I guess, and whose responsibility is it, and I think certainly it's that broad collaboration that the right to health and everybody's role in that is everybody's role. It's not another organisation or another individual. I'm going to move us on just very shortly, but final word from Duncan on this topic.
It was really just to come back and, in fact, agree with Donald. It has to be emphasised that progressive realisation is not an excuse for delay. We have very real binding obligations which apply as a matter of international law. We're increasingly, particularly within Scotland, writing those into domestic law. And the test at the end of the day is whether people's rights are realised. It doesn't matter ultimately whether we have a fancy legislative structure or, you know, a nice, well-formatted policy documents. What matters is what the experience on the ground looks like and feels like. So if we're not in fact realising human rights for individuals within Scottish society, then we are not in fact meeting our obligations. And it really is quite simple in that sense in terms of the overall context.
Brilliant. Thank you, everybody, for that. So I think we've got a real understanding in terms of what the right to health means. I think you know, that's been a really important discussion, and I think it leads us on nicely actually to, so what does it actually look like in practice? So can I open up that question? What does delivering the right to health look like in practice? Who would like to? Anna, you lead us off on this one.
Hi, thank you. So I had to think about this for, and I think I'm going to give two examples, if that's okay. If I'm whittering on too much, you can move me on, Kyle. But I suppose for me, you know, working in healthcare, the difference between the sort of solid, I suppose, legal right to health is that there's a kind of difference between that and the more nuanced ability to access appropriate healthcare. And I think for the right to health to be fully realised, healthcare needs to be accessible, and that can look quite different for different groups and different populations within Scotland. So the two examples I'm going to give, the first one is around healthcare for asylum seekers and refugees. So Kyle, as you mentioned at the start, I work in this area, both in my practice within Glasgow, I'm on the board of charity, and also I work at Dungavel. I have also just finished a PhD, took me 10 years, but I did finish it. So, and that was looking at women's access to healthcare who are experiencing the asylum system and actually around screening. So in Scotland, people seeking asylum have a really solid entitlement to healthcare at all stages of their journey, and we're quite unique within that in the UK. However, they do that within the context of a hostile environment, and they must access healthcare within that hostile environment. So if we think about examples of that, are sort of moving people seeking asylum to hotels during COVID, away from healthcare, away from their continuity, detention, forced dispersal, really negative media coverage, sort of, you know, policies such as offshore into Rwanda. And all of that becomes a discourse of sort of undeservingness. And I think for me, that's a real key thing for people when they're accessing and providing healthcare, is that thought of whether they're deserving of that healthcare. So through my PhD and through my clinical work, I found that a lot of people internalised attempts to access healthcare as that they weren't deserving of it. So they internalised all this negative media coverage. And actually, through interviewing healthcare workers, many healthcare workers didn't know where the policy was on what the entitlement to healthcare was, but they could tell you headlines from the Daily Mail. So that affects how people interact. And whilst the majority of healthcare workers gave full entitlement to health, many of them thought they were doing this under the radar and that they were just doing a good thing, but they probably weren't allowed to, which is quite sad. So that was sort of something that was happening there in that space and can really affect the right to health, because whilst the healthcare workers and the women that I spoke to kind of pushed through that to access healthcare, others might not, and others might go under the radar. So, but there are things that we can do. So I'm going to try and give a hopeful bar. I'm not going to be all doom and gloom. You know, we can facilitate things. So, you know, there's lots of work being done around Doctors of the World. I think I'm getting a parcel delivered, which is why my dog's going mad in the background. So it's really bad timing. So just in case anybody's distracted. But there's an organisation called Doctors of the World who have a toolkit for safe surgeries. And all of this, I think, is really transferable. I think things that we do for one group often work for everyone. So things like having trauma-informed waiting rooms, so welcoming places, having separate phones that people can use interpreters, having ways for people to communicate at the reception desk, because we often forget about reception. That is the first place that we have to do that interaction with people. Posters in multiple languages. I was at a talk recently and someone was speaking who was homeless and said that they hate going to the doctors, and this may be something for Public Health Scotland, because they're actually knocking at my window now. This is very embarrassing. So the thing is, we have to have posters that aren't alarming for people when they come into waiting rooms. So we have to have things where this man told us that he finds it very hard to get to the doctors, and whenever he gets there, there's all these posters telling him that because he's not been to the doctors, he's going to die in the next week because he's not had this screening or that screening, and it's just terrifying. And that really hit home with me, that is something that actually maybe we need to have a slightly more, you know, kind of welcoming atmosphere that actually you've came and there are things we're going to be able to do from this point. I think culturally informed healthcare is really important. And again, I think there's different parts of culture within that. Every interaction is a cultural interaction. And actually, it's not always about people from different countries or people from different backgrounds. Just everyone's experiences are different, and we need to become comfortable at doing that to make people feel that they can come into healthcare. And I think that comes into a sort of two-way learning process. So understanding people and why they behave or access in certain ways, what they feel about health, and actually incorporate some of that into our practice. We don't always know best. So can we learn from that as well? And providing, I think this links into what Cath said about sort of examples of providing healthcare information, because if you don't have information, if you don't have education about healthcare, how can you make an informed choice about what you want and how can you consent? So my second example, which is a bit shorter, and hopefully that man has gone away. So the Glasgow Youth Health Service, where I work, is an evening service for 12 to 19-year-olds, 26 have care experienced. And actually within the sort of right to health, it talks about adolescents. You know, adolescents are generally healthy, but they're at a time of risk-taking behaviour. We've all been an adolescent. You know, that's when you take risks. So you're vulnerable. And it's important people can take risks, but they need to have support to be able to do that in a safe way. And there's lots of focus, I think, on early years, but not on that adolescent, that leap that we have. So this youth health service is quite unique within Glasgow. I think it's a really good example of doing sort of right informed healthcare. So it was designed with young people. Young people co-produced how this service was going to look. It looked at what they wanted. So to improve access, they wanted it to be an evening service, so not to interfere with things that they wanted to do during the day. They wanted it to be in a neutral place, and that's particularly important in some areas in Glasgow that have a prominent gang culture. It needed to be somewhere that people could arrive to and no one would really ask too many questions. So health centres were seen as quite a neutral place. And confidentiality is a must in the youth health service. So we look at things such as sexual health, social issues, mental health. We have a wide sort of connection. I think Donald will approve of this, with the social care sector, with third sectors, with charity organisations, because we see it holistically. Young people are in many places, and not everything they need is a health issue. We provide nurture and warmth. So when people arrive, it's informal. I get to wear my jeans when I go and work there. We have music playing in the waiting room. You know, there's a bit of kind of youth work going on so that people can feel they can drop in and they can come in and out. I think that's a really important thing, especially for some groups of people. Healthcare needs to be accessible in the way that they can turn up and not get judgment at times, because I think the work that goes into accessing health for some people is really hard. And the worst thing that can happen is they arrive and are told off for being late or for not coming to another appointment. It's difficult for the system. It is, I get that. But I think we have to allow that to kind of create that nurture. So basically that was my two examples. And I suppose it's just I'm trying to make a point that's saying that there are common themes. So there are specific groups which we need to look at, and we see that, and there's great people doing work around homelessness, disability, women, all these different groups. But there are certain things that I think always come across. So I think time is important. I think as a GP, 10-minute appointments, we're acutely aware of that. Helpful front-facing staff, you know, welcoming reception. I think all these things can make a difference, and really good links, which again is hard work to have links with social care and third sector, because it's always changing, and to try and keep up with that. But I think things like link workers and all these are really good at improving the delivery of the right to health. So I hope that was okay.
Brilliant. That was amazing, Anna. Thanks very much for that. I think, you know, you've really given, you know, some clear illustrations in terms of what it's like in practice. I wonder if there are any other comments from any of our other panel members just in terms of what Anna was talking about there, because there's something there. I suppose Anna's given some of those real specific examples, and there's a question in my mind in terms of how we sort of foster that across Scotland. You know, how do we share that best practice? How do we learn from, you know, some of those pockets of things that are going on that would have real impact? And I think, you know, Anna's, you know, demonstrated that through those examples, that there is real impact. Cath.
Thank you. Yeah, just a quick reflection really on what Anna said, which was really inspiring and good to hear. And I think the thing that I heard most of what Anna was saying, we've mentioned already resources and resource constraints and coming out of COVID and it is important and all the choices that have to be made about where resources are allocated, and there's definitely more to do in terms of taking a human rights-based approach to where resources are actually allocated, what we do choose to fund, etc. But I think often people, and this is certainly my experience, working within health services, is that the first thing that came up is but resources, we're just really tight, we're just really tight for resources. And I hear this a lot in local government as well, all the people providing the services that are important. And that can become just such a barrier. It can just become such a, we can't do it. We're overwhelmed with lack of money, etc., etc. But actually, a lot of what Anna talked about are other things. They're talking about, it's a lot about attitude. It's a lot about approach. It's some basic things about how do you choose to make your surgery, your place of work, whatever it is people come to, actually welcoming. How do you make information available? How do you actually provide the service in a place that's going to suit the people that need to access it? So we heard that example in the youth service. So there's all of that. And of course, that still takes up resource, it takes up effort, but it's a different kind of effort. And I think getting that across and just constantly reassuring people, there's a lot that you can do that isn't necessarily about lots and lots of pound signs. It's about choosing to do things differently. It's about choosing to work in partnership. It's about choosing to, and really making the effort to do all this stuff that's so important about joining up with different services, etc. And I think that's a key message that we need to keep promoting and sharing and showing people how to do it. Thank you.
Thanks, Cath. And I think, again, you've touched on some really important points there, that concept of collaboration, working together. The fact that quite often that, we see things as barriers that actually, if we just put a little bit of thought into it, it's not, it's about changing our approach rather than needing huge amounts of resource in to support it. So I think some really critical insights there. And I suppose that maybe takes us on to another question, which is maybe a sort of broader one around public services. So what actions do we think that public services should be taking to empower their service users to exercise these rights? Donald, do you want to come in on that one?
Thanks, Kyle. And I suppose I'm very mindful of the personal story which Duncan shared earlier, and it's great to hear about your mother's experience with excellent frontline social carers. And it reminded me when I was doing other things. I used to train lots of people in different settings, but mainly public bodies, around what human rights was. And included in that was working with people with reduced or fluctuating capacity in care homes. And I always remember one lady who would be defined as and diagnosed as in latter stage advanced dementia. And I asked the question of everybody, what do human rights mean to you? And she turned round and she said, isn't it about being human, laddie? And at the one time, and that stuck with me because it is both a terrifying description of reality, but also a hopeful description of a promise. It is about relationships. It's not about the dry, dusty tomes of legislation or politics or policy. It is about an interrelationship with people who are like you, who are different to you, whom you may disagree with, whom you might work alongside. And so for me, the first thing that any public organisation or any organisation needs to think about is, have we equipped those who represent us, those who work with us, to be confident as human rights advocates, to be able to form those relationships which recognise difference in another person, and rather than run from it, celebrate it and value that other person. So it's at that relational level that I think organisations can make a real difference. Anna is quite right, and I don't know how many times people have said to me words which suggest a negativity around human rights because of what the media and a fairly toxic environment can present human rights as. But for me, they are always about dignity and always about relationship, and the best organisations whether they're public, private, charitable, or otherwise, are those which started that relational element. So the way you recruit somebody, are you giving them autonomy and personal confidence and control that they can value themselves in order to value and be better able to welcome and value others? In your supervision of staff, are you ensuring that a question about human rights, not about the technicality, but about that relational dimension, is present in all the questions you ask about somebody's performance and practice? Is the mission statement of your organisation something which has come alive, or is it just something that you've bought from an ad agency and says the right things, but actually doesn't communicate the essence of your organisation? And lastly, when we, all of us in public or private organisations, conduct exit certificates, I think we should be asking the question of our staff, what is it you're going to miss about this place? And at the end of your time with us, are you able to be more human now that you are leaving us than when you came? Because for me, that's the essence of a human rights-based organisation. Not what it says or does, but how it makes people feel, how it gives a place for them to be valued. And that is about the realisation of human rights, which can only be made ultimately by individuals, personally, organisationally, and collectively. Thanks, Kyle.
Thanks very much, Donald. And I think, a really impassioned appeal to everybody to understand that human connection. And I think you're absolutely right. How do we make that live and breathe in our organisations, rather than it being something that we set out in a colourful brochure, rather than something in terms of how we operate? Can I open that up to the rest of the panel just to perhaps share some other thoughts and insights? Anna.
Yeah, thank you. And thank you, Donald. You put it much more articulately than I think I was able to. But I think you're totally I think you're right. It's about sort of that relational piece. And I think it's about listening to communities on the ground. I was thinking when Donald was speaking back to, I did some work in Australia looking at Aboriginal and Torres Strait Islander health policy. And when you spoke to policymakers, they had that feeling of being overwhelmed. Where do we start? What do we do? But when you went into communities, they could tell you, they said, we'll start with this and then start with this, So I think there is something in there about people knowing what they need. And I think within health, if we speak to, like the example of young people, or speak to service providers, people on the ground, actually they can see what they need, but they need to be given a bit of room to look at that. And I think that's a key element. So I think when services become overwhelmed, they can't see the wood from the trees, and there's a great example in the Deep End GP project, which is looking at the 100 most deprived practices. And they had a pioneer project where GPs went into practices to give partners in the practice and staff space to look at development within the practice, and just being given that space. And I think that's the point. It's not necessarily about lots of money at that point. It was just to be given space to say, this bit isn't working. What can we do better? What can we trial? What can we change? And I think that is really, really important. And I think that's key. I think individuals and organisations do know what needs to happen, but they just need to be given room to do that at times.
Thanks, Anna. And I think, again, just, it's useful to hear that, in practice, what does it mean? Any other comments or thoughts from the panel? Cath?
Yeah, I mean, Anna and Donald, senior moment there. Anna and Donald, I mean, I've articulated it very, very well. I think it's just that relational stuff and humanness. To reinforce something that Donald said, I think it's absolutely right. For people to provide the kind of services that we want people to provide, to really be thinking about that, to having those kind of relations, it does start with the workforce as well. I think that's critically important. I think that's something that we found all the way through. And you've said it already, Donald, but the way that we treat our workforce is critically important. As we're moving into things like the National Care Service in Scotland, can we really, really, really embed the absolute not just the principles, but really take this through? You know, what would this look like if we took the opportunity of something like that to really embed equality and human rights right in the core of it? One of the pieces of work which the HRC did recently was an inquiry into the treatment and experience of lower paid ethnic minority workers working in health and social care. And we found all, you know, the negative effects of some of the things that Donald talked about. It's really inspiring to hear Donald talk about the way that you can treat staff. But unfortunately, what that inquiry found a lot of the time, that people were not being treated in that way. They were not being given the voice. They were not being enabled to speak up when they found something that wasn't right. They weren't empowered to make choices or changes because they were worried. They didn't understand their own rights, and they were in vulnerable positions anyway, and therefore did not feel able, actually, even if, and I'm sure they did want to then speak for and enforce and empower other people's rights. So that principle of workforce is really critically important, and there are real opportunities in the kinds of big things that we're taking forward in Scotland and elsewhere to really fundamentally embed a human rights-based approach in a very practical way from the beginning. Thank you.
Thanks, Cath. Thank you. And Duncan, let's come to you.
I had been going to make a very similar point to Cath, actually, which was picking up on Donald's comment. There is a bit of a tendency, inevitable tendency, to over-intellectualize some of these concepts. You know, human rights are quite often presented in a slightly abstract way as part of a grand international framework which cascades down and informs domestic legislation and so forth. But I think it's hard to better how Donald has described the reality of human rights and the impact that human rights are meant to have. They derive from the concept that every human being is entitled to dignity, that every human being has a fundamental dignity which must be respected and upheld. But what does that look like in real life? It means treating people as people. It means recognizing the humanity of the other individual, recognizing that every person is a living, breathing, thinking, feeling entity and must be treated accordingly. And we have to be very careful, therefore, not to fall into that trap of treating people as if they are kind of widgets in a factory, items to be moved around, statistics to be juggled from one spreadsheet to another. That every person matters and every person needs to be treated with dignity. So, you know, you can distill that entire human rights framework into that very simple concept, as Donald said. It's about treating people like humans. It's about being human yourself.
Thanks for that, Duncan. And, you know, I think that probably gives us a really good stepping stone to move into the next part of the session. But before we do that and start to look at the Q&A from people who are participating and open those questions up to the panel, I think certainly I'm hugely inspired by what the panel have brought to the discussion this morning. I think, you know, it demonstrates just where we're at, where the opportunity is. And I suppose, as all organisations who are represented on this call this morning, it is about challenging ourselves as we go back into our organisations in terms of how do we make human rights a fundamental aspect, not only of what we deliver, but how we are and who we are as an organisation, and how that is absolutely part of our lifeblood. So I just want to extend a huge thanks to all the panel members for sharing their thoughts in the first part of the session this morning. I think, as I say, hopefully colleagues across the call will have really enjoyed hearing what panel members have had to say. So we're going to move into a sort of Q&A session, and we've opened that up for participants to start presenting some questions. So the first question I've got for the panel then, we've talked a lot about public services and, you know, the sort of current context, but just really to get the views of the panel in terms of key challenges and setbacks faced by public services in relation to the implementation of their human rights duty. To open that up to the panel just to perhaps share some thoughts in relation to that question. Donald.
I'll just kick off. It comes to something Anna said earlier, and at this present moment in time, a couple of days before our budget is announced by Scottish Government, inevitably there are two things uppermost in my mind. One is the fact that we're facing a winter unlike one that we've probably ever experienced in social care, with a workforce which is depleted, exhausted, and burnt out. So for me, what do human rights mean to those women and men at the front line, delivering as they do, especially in these atrocious weather conditions, frontline essential care and support? And part of the answer to that is going to come in a couple of days' time in the budget. And so there is an inextricable link, and Cath hinted at this, between the way in which we choose as a society to resource and prioritise our budget and the relative priorities we give, albeit within a constrained economic environment. The choices that we make in the next 2 or 3 days will have huge significance to the degree to which these women and men and those who they support feel as if human rights are at the heart of the way in which an administration presents itself or an afterthought. So I would love to see presented on Thursday a human rights budget which has undergone a human rights audit. I'm not sure I will see that, but in its implementation and in the decisions made by local and government and public bodies, I would hope to see that at the heart of their decision making and around budget allocation and resource distribution, we have a human rights basis. And I'm not convinced that we're going to see that.
Thanks for that, Donald, and I think you're a really important point. I wonder if any of our other panel members have some thoughts, either just in terms of what Donald's just said, or just sort of building on that notion. I've got Cath, then Duncan, please.
Thank you. I mean, I agree wholeheartedly with what Donald has just said. When you first asked that question, Carol, that one of the things that took me back to instantly, you know, how do you make this kind of work in practice, and what do people need? It reminds me actually of one of the last events I was involved in just before I left Health Scotland, Public Health Scotland, to join EHRC, and it was a seminar, quite a big seminar about the right to health. And we had a lot of people in the room really engaged in this. And I remember at one of the round tables I was at, really struck me, I was working with a colleague from local government, and she was there because she wanted to be, and she was there because she was really interested to hear and learn and think, how could I actually take this and make this practical? But one thing that she said that really struck me, she said, you got to understand, she said, I can't remember the exact number, but it was well over 100, something like 146 different pieces of legislation and procedure and guidance that I have to implement within my local authority. And she said that honestly, and I thought, well, you have to respond to that. You have to think about that. First of all, we have to get this beyond just another thing that has to be done, you know, in terms of that list. But you can understand it. You can understand how that's done. And I think for me, one of the key things, my experience was always when I was working more as a public sector duty bearer, was what does leadership do about that? So how does leadership actually make this stuff and embed it and integrate it into the work that people do on a daily basis? So how you plan your services actually just incorporates how you train, how you support people. You know, the more and more that equality and human rights is not seen as another thing on the list that we want to get to, and we will get to. And there's lots of ways that we can do that. But I think leadership is a key part of that journey.
Thanks for that, Cath. And I think, you know, I really like that notion, particularly when we think about leadership in terms of that construct of influencing and influencing change, and not just necessarily in our own organisations, but what that means at a national level. And I think, you know, we've clearly got a wealth of experience in terms of that national and international influence around the panel today. But I think it is about how in that sort of local context, what that influence looks like. So thanks for that, Cath. Duncan.
So again, perhaps a comment from a professional perspective and one from a personal point of view. So just to pick up on Donald's reference to the budget, will we see a fully audited human rights budget? No, I think I can be fairly clear that that's not what we'll see on this occasion. There will be elements within that that are directly informed by human rights considerations and by equality considerations. There is an Equality and Fairer Scotland budget statement that will support the budget. But are we yet at a point where we are in Scotland doing human rights budgeting in the kind of fullest sense of that concept? No, obviously we aren't. And that's one of these areas where further work is required. It's part of that progressive realisation challenge. I don't think there's any real dispute about the overall trajectory or where we ought to be ending up. The question is about the speed at which we are progressing towards those objectives and the resource that's available to support that work. So, I mean, clearly there's an active debate around these issues, but I think we have the advantage in Scotland that we are, broadly speaking, all pretty much in the same general territory. We aren't in a position, as is the case in other parts of the UK or indeed internationally, where people are actually rejecting fundamental human rights concepts or regarding them as unacceptably problematic or disruptive or expensive or something to be discarded. So in that sense, we are in a positive place, but it's clear that more work needs to be done. But from a personal perspective, I mean, what does human rights look like in practice on the ground in Scotland? And I'm very conscious that the individuals providing social care to my mother are not themselves necessarily being treated terribly well. To take one example, I'm well aware that one of the individuals has to travel by bus from a nearby town in order to get to the people that she's providing care for. And on occasion, that has meant her standing at a bus stop in an isolated area at 10 o'clock at night for over half an hour in freezing cold conditions just in order to get back home. And that, I think, does not indicate that we are necessarily respecting the human rights of every person involved in the healthcare system in Scotland. It has to be holistic, it has to apply across the board, and we really have to mean what we say. We have to apply these concepts in practice on the ground.
Thanks, Duncan, and it's useful to hear that sort of personal illustration in terms of what it means in practice as well. And I think you've touched on it in a really key point there. I guess the question again is, as we think about what that means for our respective organisations, how do we make change happen? And I think that comes back to Cath's point around leadership and that influencing change. Thanks very much, panel, for your thoughts in terms of that. I'm going to move on to another question. This one, Anna, was related. Somebody's come into the discussion around homelessness that you touched on, and also that idea of access to primary care. So the question for the panel really is, does anybody have any reflections on the interactions between the right to health and right to housing and the relationship in terms of those areas of work? Anna.
Yeah, I'm happy to come in on that first, but I'm sure others will have a lot to say on it as well. So I think as we talked about earlier about what the right to health is, the rights are interrelated, aren't they? So I think an effect on one right puts pressures on others. So I think homelessness, particularly, is a really acute and difficult situation. We know that would lose continuity of care. I think it's also to do with, it's not just, talk about homelessness, not just street homelessness. It's also not having sort of a set place to live, a set address where you can be contacted. It's about quality of housing. We've seen a really, obviously wide covered situation of that with the child in England that died due to effects of mould within their housing. So, we're seeing actual acute issues on health and how your health is affected, which is leading to deaths and poor health. But also, I think we then see the stress on people as well. So, in general practice, a lot of what we see people about is not actually necessarily a direct health issue. They're not coming in with necessarily a symptom, but they're coming in with stress and issues that are created by these other rights being sort of degraded. So people having stress, anxiety about health situation, about home situations, and that, I think, that creates problems for the individual, because when you're in a situation like that, especially around housing or poverty, you don't have space to start thinking about your health in any sort of preventive way. You're dealing with the day-to-day, you're coping from moment to moment. So actually any sort of discussion about smoking or any of these things, or even just long-term screening or any problems, that's not, nobody's got room for that in that situation. They're trying to provide for their family and they're trying to survive. And I think that just builds up, you know, the problem of that builds up, that toxic stress builds up. And also it puts pressure on, from a systems approach, it puts pressure on the systems. You know, an issue in housing creates, you know, and this isn't me complaining about it from an individual level, obviously we do everything we can to help our patients, but it takes up time then in health to write letters, to see people about the problems that are coming from that. It takes up room in social care. So all pushes, and it all pushes that sort of balance within the systems as well, and creates burnout and stress. And I think, coming back to what Duncan was saying, you know, people that work within the system as well are humans, and they have these issues that are happening. And we're seeing that even more in the cost of living crisis at the moment. People are really struggling. And actually, then when they're coming into a system that's breaking and struggling and are overwhelmed, it's becoming a bit of a boiling point, I think, you know, and I think that is causing burnout and even more stress within that. So I think it is a thing where everything is interrelated.
Thanks for that, Anna. And I think, again, you've touched on some really key points in there. I wonder if any of the other panel members want to come in on this. Donald.
I think we have to own up to the reality of human rights hypocrisy, and take, for instance, the situation regarding to the tragic circumstances of the young boy in England who died from the effects of mould. We know that in the map of social housing in Scotland is complex, and yet within days we had positions being taken about how one group of providers was attending to this issue better than another group of providers. Take Duncan's issue about the fact that those workers have to endure fairly challenging circumstances in order to get to their work. It's true that for much public funded social care provision in the community, the worker has to pay for their own travel time. Can you imagine a nurse in an NHS hospital only being paid for the time they spend with people and not the time they take to walk from patient to patient or ward to ward? You can't. That's where hypocrisy exists, where we fail to recognise the holism and the whole system, but we treat parts of the system, and therefore people within the system of housing, of health, of social care, in a distinctively discriminatory manner. That's where the hypocrisy is, because I have no doubt that the local authority who perhaps commissions the care and support, which enables that worker paid by a charity or a private provider to have to pay themselves to travel to work, celebrates the fact that they're a champion and a living wage employer or a human rights protector. And we have to call out that hypocrisy, and that involves leaders calling out that hypocrisy of inconsistency.
Thanks for that, Donald. I'll come to Duncan.
And that rather nicely, I think, it reminds us that there's an elephant in the room. It's one that Anna and others have referred to, but it's that connection between power inequality and health inequality. And there's been some, significant work done in this area in the past, but I don't think we necessarily have internalized or acted upon the messages emerging from that kind of research, or indeed the fairly self-evident examples that we see in front of us. So we know that people who suffer from marginalization and deprivation are statistically more likely to suffer from health problems, so that their right to health is necessarily compromised by the fact that they suffer from fundamentally an inequality of power. People who have power tend to allocate resources in ways that benefit them. People who do not suffer the consequences of not being able to do so. And that clearly also applies in the context of the workforce, so that, as Donald's indicated, there are there is a differential across the health system in Scotland in terms of the ability of people in different roles to influence the conditions in which they carry out their functions in which they work. So we can't really get away from this kind of recognition that at the end of the day, human rights are also about power. It's about that ability to be heard, to be recognised, to be taken seriously, and for resources to be allocated in a way that actually is necessary in order to meet your fundamental human rights requirements.
Thanks for that, Duncan. And I think, you know, again, it is just that holistic view in terms of how we shape this in Scotland. Moving on to the next question. So what did the panel think about what's currently provided to assist disabled people access their right to health, such as accessible transport to get them to health services, or contact with them in formats such as Braille or email? There are pockets of good practice, but mostly disabled people are left to navigate these aspects themselves. So I think there's been a couple of comments from the panel in this space already, but let's open that question up to the panel just to get their views specifically relating to disabled access. Who wants to go first? Donald, thank you.
I had the privilege of managing a learning disability project in Glasgow a long time ago, but it was following the closure of long-stay institutions, and it brought together health, education, individuals at the heart of the delivery. And we've made a huge progress in enabling people through information, through greater awareness, through changing accessibility to service provision. For instance, the bit I was more involved in was around screening, around helping individuals with learning disabilities gain greater access. But we have some considerable distance to go. You know, I don't think life has changed all that much for the parents and families who I used to work with and who I had the privilege of being on a charity board for, with profound and multiple learning disabilities. They are still marginalised from receiving the adequacy of health provision, which is sensitive to the particular needs of those individuals. There are still gaps in provision, not least in terms of mental health and care and support at transitions in life. And Anna rightly spoke about, you know, the upper age, teenage, adolescent age. But my concern increasingly is for people with disabilities, particularly intellectual and learning disabilities, who are thankfully living longer and into their 50s and 60s and 70s, but around whom there is a wholly inadequate provision which recognises the particular needs that they have. So for them, yes, we are so much better than where we were, I have to say, 25 years ago, but we have some considerable distance to journey for the full realisation of health for people with physical and learning disabilities.
Thanks for that, Donald. I think that again just, you know, helps to really set the context and some of the challenges that are still seen. Anna, would you like to come in?
Yeah, it's just a short comment. Donald put that so well. I think recently I heard a friend speak about her son who has had additional support needs, and she talked about how difficult it is to advocate for a loved one or for people to advocate for themselves without using quite derogatory language. And often we have to say this person, and it really made me think, this person has complex needs, they are challenging. And actually, what does that, you know, this is just a quick kind of thought because it was really struck me when she talked about this. What does that say about the dignity of that person or the dignity of that family, that for them to get support and for people's rights to be realised, they have to use that sort of language about their family member or their son? And it really struck a chord with me, and it made me think about letters that I have written, and, you know, as a way of supporting families, patients or friends around this. And actually, you know, she's totally right. The very basis of how people have to ask for help in that sphere is really degrading. And I think there's something, I don't have an answer, but I think there's something there that we have to look at that people shouldn't have to, comes back to that deservingness notion. I think people shouldn't have to perform to be able to get their rights met, and there almost is something around that. And I think particularly for people living with disability is often there's a sort of, or people caring for people, I'm sure Donald sees this, you know, that they have to look a certain way or they have to break down in a meeting in order to get the help that they need. And actually that shouldn't need to happen.
Thanks, Anna. I think really powerful commentary there. Duncan, can come to you.
All of this can be quite helpfully linked back to how one conceptualizes the right to health. You know, what really is health? What do we mean by that? Cath referred right at the beginning to the World Health Organization's definition, and I think it's a really rather useful one that it's worth bearing in mind when trying to understand what we mean by the right to health. So the WHO is explicit that the right to health, or health, is not merely the absence of disease or infirmity. It's actually something much more holistic and positive in its nature. And it really is a state of complete physical, mental, and crucially, social well-being that is experienced by the individual. So it's not sufficient simply to cure the disease or support the infirmity. It's necessary actually to look at the entire context, including that social dimension, and that's the element that all too often we do forget. I think we've become much better at remembering that health is not just about physical health, it's also about mental health, but we have yet really, I think, to take that further step and say it's also about social well-being.
Thanks, Duncan. Again, really great insights. I'm just very conscious of time, so before we get Moira, I'll open it out to you just in terms of the next steps around evaluation. But there's one more question that has come in that I would like to ask each member of the panel to share their thoughts on, if possible. So apologies if I come to you first, because you probably won't have the same amount of time as others to think about your response. But the question is, what would be your challenge to each person on this call as our call to action following our discussion today? I'm not going to pick on anybody to go first, but so whoever wants to respond to that first, off you go. Cath, thank you.
Sorry, I did a real hand there. Too many buttons. Two things. I think there's two levels that I would put back as a challenge. So one is just that core aspect of humanness that we've all talked about. We are all human beings. We all have that agency to think about how we interact with other people, how we role model, how we challenge, how we do it, how we think about it, and how we bring just normal human language into what we talk about. And, you know, what Anna just said really struck me about that. You know, if you make all of this, if you actually normalize human rights language, the fact that we're all human beings, we deserve and we want to give each other respect. And I think that does land with people. I think that does, when you talk about that, I think it does inspire people to think about how could do that a bit differently. So first, just think about things in terms of human interaction. And the second thing is back to leadership. I think it's really important, and all of us, and I don't know who's all in the call and the different roles that people have, but there will be people who are in assigned leadership positions, and there'll be other people who can influence that and can think about it. But that idea of leadership and justice is about a whole system, and whole system leadership is a great phrase, isn't it? And it be used a lot within Public Health Scotland, I know that, and we talk about it. What does that really mean in practice? It's about making this everybody's responsibility, and that's really key. So when you get to things like, well, housing somebody else's business or health is our business, we have to be joined up and think about holistically, how does this come together? And there's every level that we can hold ourselves to account. Government to set accountability frameworks to do that, organisational level, but individual level as well. Thank you.
Thanks for that, Cath. And I think you've touched on, you know, absolutely the things that have been key themes throughout this discussion. So thanks for bringing that to life. For everybody who's participating. I've got Duncan, then Donald, please.
So firstly, just to endorse everything that Cath has just said, I mean, that's exactly where we should be. I'd offer not so much a challenge as an encouragement. So quite often human rights can feel esoteric, intimidating, abstract, distant, overly legalistic. So my encouragement would be not to be intimidated by any of that. These concepts are actually, as we've heard from the discussion, really quite simple in their basic content and implications. You know, you will be able to judge in any given situation, in essence, whether something feels right. If it's not fair, if it's not dignified, the chances are that in a kind of strict legal analysis, on a technical analysis, it's probably not human rights compliant. And the important thing is to, you know, as we've emphasized throughout the discussion, to see the human, to treat people as humans, to be human yourself.
Thanks for that, Duncan. Donald.
I'm just reflecting on that group of people that I worked with when I ran a learning disability project. And one of the things we always did was to do what became known as person-centered planning. So how do you plan for a life for somebody with them at the center, making decisions, control and choice? And each of the models are different, but they all contain two elements. One is that there's a North Star, there's an aspiration, there's a destination. And I think all of us personally need to ask ourselves, including myself, what is the human rights destination, the North Star, the aspiration that we want to move towards? Because without that pull us through the really hard and challenging times, we can lose that sense of agency and direction. But the second thing they all had in common was the realization, to paraphrase, that a journey starts with an initial first step. And that we've got to be able to very practically think today, what can I do differently, or how can I behave differently, which will make the achieving of that destination more likely and more probable. And lastly, nobody journeys alone. We, all of us, need the companionship of others, and the achievement of human rights will never be something we achieve on our own, but in community with other people. But we need to be encouraged to look for those fellow travellers. Thanks, Kyle.
Thanks, Donald. I really like that idea of journeying together. Again, we wrap that up in that whole notion of collaboration, but I think you've illustrated that in a much more human way than perhaps some of the other language that we sometimes use around that. Last but by no means least, Anna, your thoughts and reflections in terms of that call to action.
I thought I should have let Donald be last. He's more profound than I think I can speak. So, but I think I think two things again. I think moving on from what Donald was saying, just that see the person. I think when we talk about human rights, and Duncan sort of alluded to this, at a high level, it feels quite complicated and legislative. But actually, when we come down to people and we think about people we know and what they need and what, makes them thrive, it actually becomes a lot clearer. So I think then the second thing is, obviously, I'm on the board PHS. I'm a huge advocate of the importance of data collection and the need to monitor health inequalities. And we saw issues with not having enough data around certain groups during COVID. However, I also feel that, we know what causes health inequalities. We know that. We know where the problems are, and we know where we're headed in the current climate. We know that cost of living crisis or recession, it's not going to take us a good place for this. So I think there's also something around, being innovative, listening to people on the ground, knowing what's coming and trying to prevent it at a systems level, a high level and an on the ground level. And I think something that always strikes me is, in COVID, we made fast changes. Now, some of that we can reflect on, maybe weren't the right things to do, but we made fast change. And I think we don't have to do things at a snail's pace. So I think when we see what's coming, we see the difficulties that individuals and communities are going to face, and that there is going to be, I think, an increase in health inequalities coming. We need to start making those changes quite quickly and putting in things to try and protect people, and also protect the systems and the people that work within the organisations.
Thanks, Anna, and thanks to all panel members. I mean, I think it really has really brought it to life in terms of what we need to do, and hopefully colleagues who are on the call are going away from this not only with an enriched idea and concept in terms of what we mean by human rights and what that means, but actually just that whole idea of what they can do to make things different, how they influence that. And I think it does come back to what Cath said in her summary around how we humanise it and how all of those things feel more human in terms of the work that we do and the organisations that we work within. We're getting quite close to the end of this session. I'm just noticing that there is an evaluation link that's maybe popped up onto people's screens for participants to complete. So if participants can review that. We're also going to rerun the poll for participants, and that was really just to provide a bit of an update in terms of how you rate your knowledge about right to health, how that has moved as a result of the discussion this morning. And I think just in terms of Moira, is there anything else that I need to pick up before I sum up?
No, that's perfect. Yes, if all participants could please go in the Q&A chat panel, that's where the link is. You can fill it out now or after. It would be brilliant if you could complete it. And also thank you for participating in our poll, everyone. Yeah, that's great. Thanks, Kyle.
Brilliant. Well, listen, I would like to extend a massive thanks to our panel this morning. I think the insights, the real gravity of the insights and how that has really, certainly I can only speak on a personal perspective, but how that has inspired, made me reflective in terms of how I do my role within Public Health Scotland, and how I sort of take that influencing role, that leadership in terms of what the right to health means in the work that I do, and actually my influence in terms of what I can do within my organisation to really live and breathe that through everything that we do. So a massive thanks. I think it has been a hugely inspiring discussion this morning, and as I say, a massive thanks to the panel members for their time and for their responses. And I think their honesty in terms of just bringing this to life in the discussion this morning. I'd like to extend a huge thanks as well to colleagues who put the session together. So they're on the call this morning, in particular Moira and Lavetta, who have really pulled the whole session together. They've kept me right at every step of the way in terms of making sure I've done the right things in the right order, but also just getting the tech to work for us this morning. I think it's actually worked brilliantly. So massive thanks to them for doing that. And I suppose my final thanks to everybody who's participated in the call this morning. Again, thanks for giving up your time this morning. Hopefully you're leaving this call feeling as inspired as I do, and with that real energy now to go back into organisations and reflect on the discussion this morning. So huge thanks to everybody. I hope that we meet again soon, and I think it would be useful to perhaps reflect on the work that has been done as we sort of get deeper into how right to health is practiced and the impact that it has to the people of Scotland. So a huge thanks to everybody. Take care, and it's been a delight to moderate this morning, and I hope I will see you all soon. Thank you.